All right, we're recording now. And Dr. Nell, have fun with your presentation. Just tell me when you want to advance the slide and we'll go from there. Let me see, I'm going to share my screen. There it goes. It's up and going.
Awesome. Well, good morning, or unless it's good afternoon for whenever you guys are watching this. But I am glad to be here, still here, even though I don't get to see all your beautiful faces, which makes me sad. But we are just going to plow right through. And welcome to the world of pediatrics. I'm a pediatric hospitalist, and we'll go into that a little bit later as far as what that is. And I work at the Children's Hospital of Colorado main campus, which is right up in Aurora, right up the highway from you guys. Okay, next one. So a hospitalist is one who primarily takes care of patients in a hospital. There's adult hospitalists or internists that are hospitalists, and then there's also those on the pediatric side. It's really a developing field. Actually, pediatric hospitalist became its own subspecialty as of about 1.5 years ago. So we're very proud of the fact that now you actually have to have an additional training after your pediatric residency. Maybe someday I'll see the increase in my salary, but not quite yet. So pediatrics is the care of patients from birth through teenage years. Some people cut off at 18. Some other pediatricians might still see their patients through college. But every once in a while, I think my oldest patient that I took care of at the Children's Hospital was 37 years old. And she had a form of dwarfism, and they just thought that it was safer for her to be seen at our hospital due to our smaller equipment than the adult side. Next. So pediatrics, if a general pediatrician is considered a field of primary care, it's a 3-year residency after medical school. And then whatever you can think of on the adult side, we do have it on the pediatric side. So when you think of cardiology, which is study of the heart, we also have pediatric cardiology. So everything that is on the adult side, we have it on the pediatric side. Pediatric rheumatology, pediatric emergency medicine, all the ICUs, with NICU is neonatal ICU, PICU is pediatric ICU. So we have them all just on the pediatric side. Next. So way back when, people thought that you should treat children just as little adults, but actually we have found with further study, primarily during the late 1800s, that is not the case. So the transition from fetal life, so inside mommy, to the neonatal life is a huge change, and really every organ system goes through a change. The big one that you might think of is the lungs, because obviously the newborn baby needs to breathe air, whereas when they're inside mommy, they are just based on an umbilical cord. But we see a lot of changes during that switch over in the heart and in the skin, the kidneys. Every organ really goes through a change. With pediatrics, we all obviously have congenital anomalies, so this can be as easy as what we all might be familiar with, which is trisomy 21 or Down syndrome, but there are many, 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 many more things that can go wrong, unfortunately, beyond that. Children are physically different, which is why, if you think about it, why do kids have different car seats than adults do? And that's because they're physically different. They have larger heads, they have a larger body surface area. So when we start trying to calculate how medicines and pharmacy works, we have to kind of calculate things a little bit differently. Also with pediatrics, we treat the family as well as the child. If I have a 2-year-old that comes in with pneumonia and I discharge them with an antibiotic, I have to make sure that there's somebody at home that will be able to give that 2-year-old the antibiotic that's needed. So I really have to treat the family as well, which can sometimes be challenging in my job. And then there's also legal implications of being a pediatrician. We are child advocates, just like teachers are, just like police officers are, so are doctors. And it is not infrequently that we might be called to court to be a child advocate. Next slide. So I'm going to go in with a little example for you guys. In your attachments is some normal pediatric vital signs. So vital signs is your heart rate, respiratory rate, your oxygen saturation, your blood pressure, and your temperature. And just like I said in my last slide, children are not adults. So when you watch your movies and somebody comes on a gurney running through the ER and they start throwing out heart rate is, blood pressure is, blah, 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 and falling, it's different for kids. And it's kind of a neat way that I kind of quiz my medical students when they come through the rotation with me. But so I'm going to make you a pediatrician for the day by looking at those vital signs. I'll explain some of these pictures though before we go. The top two pictures are where is actually Laredo, Texas, so it's a border town, and border medicine is fascinating. You get a lot of things that you might not see in this country because it's due to access to healthcare or whatnot. Diseases might be in more advanced stages than you would see in other places of the country. So border medicine is fascinating. This bottom picture is me as a medical student. I'm there kind of front and center. This was one of the community vans that would go around to some of the small kind of Pueblo towns along the border. But this above, as far as the what we did was health fair. And so this was at a high school. I showed up at whatever time I was supposed to show up, and this line along this building was all the way down that building and around the corner. It was a free healthcare, and it was quite impressive. I was pretty shocked at how many people showed up and how many people we screened during that health fair. It was a lot of fun. Okay, next slide.
Okay.
All right, so one of the things that pediatricians deal with a lot are rashes. And it's kind of interesting because you can say, oh, rash, whatever, no big deal. But the etiology of what causes a rash, since the skin is considered an organ system, is pretty fascinating. So this is what I would ask for my differential, and it's a very long list, to my students who might come through. So what could cause a rash? There's some cancers that present as a rash. It can be a contact or an irritant. It can be platelet and coagulation disorders. Some of the autoimmune diseases and lupus and arthritis might show up with rashes. And then some cool things like, different, that what we do see it is HSP, Kawasaki's disease. And then of course what you might think of, which is allergies. And I just kind of jumped around on that list a little bit, but when you think of the etiology of a rash, it's quite extensive. This picture that's of this baby on this slide is actually a bacterial infection. Next slide. Okay, so part of my job as a pediatrician is a lot of my patients don't necessarily talk to me. So I have to use my observation skills and have to put them pretty keenly. So if I was with you in the classroom, I would ask for your participation as far as, what do you think of this patient? She's a 6-year-old female, previously healthy, presents with a 1-day history of rash. And so the minute that I walk into a room or see my patients, I immediately make an assessment. So for this little girl, she's looking at me. She looks like she might be a little timid, but I might be able to get her to communicate with me with a little coaxing. She doesn't look horribly ill, so immediately my suspicion as far as something super serious goes down. But if we were also together, I would ask you what questions you would ask. So questions that I would look for my medical students to ask would be, so it's got, so the time period, but we already know that it's a 1-day history of rash. So has it spread? Does it itch? Has it gotten worse? And trying to figure out kind of the, has this ever happened before? Does anybody else in the family have a new rash or anything that looks like this? Have there been any other symptoms like fever, runny nose, vomiting? These would be all the things that a medical student and then therefore us as well would ask to try to start narrowing down that big list that I showed you before, to try to start narrowing it down to, as far as what might be going on. So next. So this is then your medical assistant might give you these vital signs. So I would ask you to look at these vital signs compared to your normal pediatric vitals that I gave you as far as on that handout. Obviously, looking at this really quickly, I would say that the bottom two, your oxygenation, 100% on room air, that's great. Your temperature, that's a normal temperature in Fahrenheit. We often work in Celsius, but I think I was nice to you on these slides and gave you Fahrenheit. Your respiratory rate is also normal. Your blood pressure, that blood pressure in an adult, you would kind of maybe take a second look, but in a child, that's a normal blood pressure. And that heart rate as well would be a little bit high in adult, but it's normal in a 6-year-old. Next slide. So this is the rash. Obviously, I kind of grabbed these pictures, but this is the rash that she shows you. And then I would also ask if we were in the classroom, if anybody has seen this rash before, because this one is not that uncommon. Next slide. So that is poison ivy. It's a contact irritant. So basically by touching it, it's a contact allergic reaction. It can slowly progress. So it can kind of get bigger. The oil of poison ivy can live on your boots and your clothes or your coat or whatnot. And so as far as treatment goes, next slide. And it's really whatever grandma says or whatever the patient comes in and says, well, I've been doing oatmeal baths, and I'm like, fine. Anything to kind of cool it or calm it down. If things get really bad, I will give steroids, but I would try not to do that if I don't have to. Next slide. All right, so rash. This one is your irritant in contact. I have that highlighted. And also just an aside, this picture on this slide is actually one little girl and 2 little boys. And it's not uncommon for parents or family members to really wonder, worry, or question whether it's for 2 little boys to dress up or pretend to be girly things is a rise of concern or just a rise of questioning as far as if there's anything deeper going on. And the answer is at this age, not really. It's very normal for girls to express being in the male gender, and it's also very normal for little boys to express themselves in the female gender at young ages. Next. All right, so this is another cool thing about being a pediatrician. Since we are primary care, we're needed all over the world. So this is another trip that I took. It was right after my residency, and it was with the AAP, or the American Academy of Pediatrics, and this is Vietnam. So the picture of me is working at one of the orphanages, and that baby that I'm holding was dropped off the day before, and with anonymously, so we didn't know anything about that baby, but that baby just still did have her umbilical cord on. The picture on the bottom is the dorm rooms. So as you can see, they sleep on thin little mats. And then also on the next picture is a common classroom. So, and then the picture of the little boy with the sticker on it, part of my group, I think there was 100 and some of us, were surgeons for cleft lip, cleft palate, and that's how we identified the patients coming in cleft lip, cleft palate, which is, there's different degrees of it, but it usually involves the upper lip and the upper hard palate, could be soft palate. They take several different stages to repair. So we were coming back through basically with some of our surgeons, plastic surgeons, who were going to do another stage of repair on that little boy, but that's how we identified who they were, was they put it on their forehead. Next slide.
There we go.
All right, so here's your patient number 2 of the day. He's a 3-year-old male, previously healthy, presents with a 3-hour history of fever. So that alone kind of should peak up my ears as far as 3 hours. This mom's really concerned. So the fact that this kid's only been sick for 3 hours. So number 1, it could just be mom being very concerned, which is part of my job as well, is to hopefully make them feel a little bit better that everything looks okay. but it also might be, and I really trust mom's instincts, is that she might really have a gut feeling that something's really wrong. So if I walk into this room and I see this kid, and my immediate observation skills, my ears are also perked up again. This kid looks pretty limp. It doesn't look like he's gonna fight me at all. He looks like he really does feel pretty bad. And that hand there is almost looks like maybe a mom or somebody is actually almost kind of holding him up. A 3-year-old is basically is an advanced toddler, and they should be climbing all over and asking questions and pushing this and poking that and pulling that. And that kid doesn't look like he's interested in anything. So my next thing that I would do after walking into that room would be to ask for my vital signs, because I wonder if he has a fever and that's why he's not feeling very well as well. So if I could have my vital signs, and you guys can look on your little sheet and see what you think. All right, so your vital signs at the very bottom is your temperature. So yeah, he doesn't feel well. He's got a high temperature. And then when you go up to your heart rate up on the left, he's got a heart rate of 160. That's pretty high. Even for a child, that's pretty high. Your respiratory rate at 50 is also pretty high. Good thing your oxygenation is fine on room air, and your blood pressure is actually okay. Children are different as far as adults go, that when adults feel sick, they will drop their blood pressure pretty quickly in their disease course. Children are a little different, and it's one of the reasons why adult ER doctors don't trust kids, and I fully agree with them, is they will keep their blood pressure, and then when a child drops their blood pressure, they're circling the drain. It's the last thing that they will hold up their blood pressure for as long as possible. But if you have a child who's dropping their blood pressure because they're sick, you got to act fast. So just another example of how kids can be different and sometimes can be scary too. Next slide. All right, so this is the rash. The last rash was, you kind of could see vesicles and possibly in lines and whatnot. This one is definitely scattered throughout. This is actually the patient's back. And they look kind of big and irregular in size. This rash, I can even tell just by looking at it that it's non-blanchable, which means when I press I'll do it on myself. Like if you press your skin and you can make the rash that spot of the rash go away for a quick second, that's called blanchable. If I push on it and that rash looks the same with pressure, that's called a non-blanchable rash. And a non-blanchable rash is definitely of higher concern. You have to have a very good reason of why a rash is non-blanchable before you think about sending that kid home. Next slide. So here's some more examples. That's an ankle and a belly button and an arm and I think maybe another leg. But as you can see, they're kind of dark and purple, especially that ankle one on the bottom right. This is a concerning rash, and you better not be sending this kid home. So what is this? Next slide. So this is Meningococcemia. It's a bacteria, otherwise known as Neisseria meningitis. Our abbreviation that you'll hear across the ER is, oh, he's got meninge. So it's a gram-negative diplococci. It's aerobic. It's found. I have what it looks like under the microscope for any of you who are super into that, which can be kind of fun sometimes. So diplococci means that they are circles, and they're diplo, the DI just means two. So you can kind of see them under that microscope slide, how there's the two of them kind of hang together a little bit. It's a bacteria that's only in humans, so no, you cannot get it from your dog or from that petting zoo. What's scary about it is 40% of adults have it as normal flora in their nose. There's different strains of it, and it's based on what continent you're currently on. And this one you'll hear about it and it'll hit the news. We do have a vaccine for this one. This is definitely before you go to college or before you go into the military. This is one that would be required. The story that I usually share when I'm doing this in class is that I had there was a ride board as far as if you wanted to ride to someplace, and I was a freshman and I was in Nashville, and I had a friend who was at Georgia Tech in Atlanta, and I wanted to go see him. So I checked the ride board and found a girl who was from Atlanta who was driving home that weekend. And it's like, great. So then you share the gas money. So she called me about 2 days before we were supposed to leave. And it was a girl that I had never met before, but she lived at the dorm next to me. And she's like, I'm really not feeling very well. So I'm going to go home early and go home today. But I have a good friend that I went to high school with who's also going to Atlanta this week. And you can catch a ride with him. I called him and he's going home this week. And I said, perfect. Okay, well, I hope you feel better. So sure enough, got the ride to Atlanta, got picked up on Sunday to come back. And the guy that I drove with basically said, he's like, how well did you know her? And I said, oh gosh, no, I didn't know her at all. And he knew her a little bit, and she had died that weekend, and she had died from this. It comes on very fast. It's contagious, and yeah, it can be very devastating. So that's why a lot of times these might make the news. So the good news is, though, we do have a vaccine for it. So next slide. So your symptoms of meningococcemia are headache, fatigue, fever, neck stiffness, nausea, vomiting, and this rash. So similar to other type of viruses or whatnot you might have, the rash is one of the keys for us. Next. So treatment is rapid antibiotics. And then I basically support your body to fight off the infection. So if I need to intubate you and have a machine breathe for you, I have obviously IVs going, a lot of different things. If I need to give you blood, and then dialysis if your kidneys shut down and I need to, I have a machine that can work like your kidneys do. And then everybody that's been in contact with this person also gets antibiotics. Next treatment, or next slide. So why is meninge so bad? Well, as my story told you, it can have, death can be a consequence. Also, deafness can be. And it's basically the rash, and what happens in the organ systems is it's dysregulation, I guess, of the clotting. So like a scab is what happens when you fall and scrape your knee, and then that stops the bleeding. So that whole system, as far as clotting and bleeding, that whole system gets really out of whack. And so it's these small little balls of a scab, basically, is a way to think of it, that gets showered into the rest of your body. So that showering, by the time it hits the really small capillaries, it can block things, and anything downstream that doesn't get the oxygen that it needs, the glucose that it needs, and gets the carbon dioxide taken away that it needs to, those cells die. So anything downstream of these clots can be affected. So next slide. That's called infarct. So when these little clots, or these little scabs that are in the blood vessels, get really bad, then you can see this. So anything that's kind of dark is cell death at this point. And so how do we deal with cell death? We call the surgeons, and we ask the surgeons to kind of clean out all the dead cells. So next slide. So both of these kids, I would be calling the surgeons on. This baby to the left, you can see there's a lot of dead cells and dead tissue on the knees that need to be evaluated. And then this one on the right, I believe, is a hand. It's hard to tell. But yeah, all that needs to be taken to the OR and cleaned up. Next slide. So if things get really bad, then things have to be cleaned up. And if the surgeons think that there's a lot of dead cells and dead tissues, then they will take aggressive measures to save the patient's life. Next slide. All right, so that was an example of our rash, and here's our rash list again. So number 2 is infectious causes of rash. That other one, I'm sorry, which is the bacterial reason, but also the rash was caused by the platelet or coagulation disorder. Those were those infarcts. So really there were 2 reasons why this patient had rash as a symptom on presentation. Next slide. All right, so I promised you there's a vaccine for this one. So it's called Menactra. They will, sometime during your teenage years or before you go off to college or to the military, this will be one that they will offer. And based on my personal story before I even went into medicine, I highly recommend it. Much less now being a doctor and having to see meninge several times, I still highly recommend it. All right, next slide. All right, so here's another little fellow. I also went to Honduras, and this little guy came to see me. He was the youngest of 12 kids, and he was a hoot. So he was a 3-year-old male, previously healthy, presented with a rash for 6 months. So immediately looking at him, he was playful. He was actually running around the room, and I had to chase him. And here, come show the students what you did. No, come here. No, come here. No. Okay. So if you'll show his vital signs. Yep. He's got blood all over his face.
Uh-oh.
So what happens when you're a mom and a doctor at home. All right. So when you look at his vital signs, you'll also, and you compare it to the little sheet that I gave you, you will also see that there really is nothing to be concerned on his vital signs. He had this rash for 6 months, which also kind of takes my concern down a little bit. A rash that lasts for 6 months, I'm wondering why I'm seeing it now. Obviously, if the parents aren't too concerned, I'm thinking I might probably not be too concerned as well. Next slide. So this is the rash, and believe it or not, especially in tropical areas, I will see this a lot, as well as if you go to tropical areas, you will come back with this a lot. So even though it can be dramatic, even though that this can scar, even though the red scar like maybe not permanent lifetime scar, maybe like 1 to 2 years, you'll still see a mark. And this is just insect bites. So next slide. Especially around the ankles and the lower legs, they can be pretty impressive. So there's your list of your differential as far as what can all cause a rash. And so that one would be bites and infestations. Next slide. All right, here we go again. 16-month-old female, previously healthy, presents with fever, cough, red eyes, runny nose for 3 days, and now a rash that started today. So looking at that, if I would look at the chart, yeah, you can leave that up. That's great. I would say fever for 3 days. Okay, so this kid's been sick for 3 days. So then my next thing is I look at the vital signs that my medical assistant got for me. And immediately, and this is what I'd ask you if we were in the classroom, what do you see? I see a super high temp. That one's even higher than our previous kid at 104. Oxygen stats are still fine. Your blood pressure is a little borderline. Heart rate's high and your respiratory rate's high. And then looking at this kid though, I was like, well, I kind of would probably look in his mouth a little bit to see if he's dehydrated at all, but his rash is pretty impressive. So I would note that his rash seems to be worse on his head than on his torso. Those spots are not discrete, so it looks like those spots kind of grow into each other. So that would be something that I would notice as well. These probably are blanchable. It looks like, especially the ones that are maybe near his temple, that it looks like I might be, and his cheek, that I might be able to feel this as well. So they're probably not flat. Okay, next slide. So what is this? So here's more of your physical exam. So the picture of the nose is a runny nose. The eye means kind of the white parts of the eye are reddish. The mouth, you can kind of see marks inside the mouth a little bit. And then once again, that rash kind of shows that it's worse kind of around the ears, behind the ears, on the cheeks, then it kind of goes down to the rest of the body, but it seems to be more significant on the face. Next slide. So this is measles. Dun, dun, dun. This is a virus. It's a paramyxovirus. It's an RNA virus for those of you who like microbiology. It's the #2 infectious disease killer in the world. It's only in humans. It's spread via respiratory droplets, which I think the world is starting to learn what respiratory droplets are more than they ever had before due to COVID. But measles is much more contagious than COVID is. It's probably outside of smallpox, it is probably the most contagious disease that we have on this planet. Enough so that your respiratory drops if you sneeze or you cough, and then somebody could walk through that space hours later. Hours. I've seen reports anywhere from 6 to 10 hours later, they can still pick up those that virus and those respiratory droplets. So when COVID really hit, and had been watching it even in China before it left mainland China. My big question is how contagious is this? So, because I kept saying when people were asking, as long as it's not measles, as far as contagious as measles is, here, show everybody what you got. Say hello. Show your eye. Show your eye. So as far as how contagious it is, if COVID was anywhere near measles, our COVID conversations would be extremely different. So luckily, okay, go wash that. You have blood everywhere. Go wash that. So, our current pandemic would be very, very different if COVID was as contagious as measles. So that was one of the things that we were trying to figure out right when we were learning more about COVID and what all of medical professionals' discussions were, is how contagious is this thing. So the other thing about measles is there's a 10 to 12 day incubation period, which is kind of long, which is also similar to COVID as well. Is the long incubation periods are harder to, as far as contact trace and whatnot. With measles, you can be contagious for 1 to 2 days before symptoms and 4 days after the appearance of the rash. So you are pretty contagious for quite a long period of time with measles. So back in the day before a vaccine, there'd be a lot of people that would have measles, and then they would pass those antibodies. A mom would pass those antibodies through the umbilical cord to the fetus. And then a lot of our vaccine studies were based on those babies. And the immunity that babies get from a mom who has had measles versus a mom who has just had the vaccine is actually different. And there's a lot of people that don't realize that. For measles, it's a permanent immunity. Also another question that we as physicians have been wondering about COVID, that we are still all around the world, doctors are still trying to figure that out. But measles and chickenpox are ones that we know is a permanent immunity, and we've been praying for a long time that COVID would be too, but it's starting to look like it's not. Oh, no. And then with measles, the virus and the sickness is worse with the very young, and then also the malnourished. So measles, especially going through the African continent where it is pretty common, can be quite devastating. Those research studies out of that continent has shown that vitamin A does help. But also those kids were vitamin A deficient. So when measles hits industrialized countries like our own, which it has been in the last 10 plus years or so, we've been having waves of it. We automatically give vitamin A, but to be completely honest, we don't have studies based on whether vitamin A is helpful or not in kids, what we would assume is normal nutrition, since all the vitamin A studies came from the African continent and from malnourished kids. Next slide. So symptoms, you can see the rash once again in this kid. So there's something called Koplik spots, and that's the picture on the bottom right. You can kind of see it with the tongue blade. It's white spots that are basically next to those back bottom molars, and you can see it on the inside cheek. I had a resident following me one time at Children's, and he was from Africa. And I do like to talk about measles when I'm teaching, just because we are seeing more and more outbreaks of it, and it's a big deal. This is not chickenpox. Measles is a big deal, and I'll get to that in a little bit. But I asked him, said, how many times have you seen measles? And he kind of rolled his eyes and kind of smirked. And gave me the acknowledgement that he has seen measles very frequently. And then I asked him, how many times have you found the Koplik spots that we normally know helps us diagnose measles? And he said only once or twice. So even though it's something that I know my medical students hang their hat on as far as board questions or whatnot, unfortunately, is when it push comes to shove, and us being clinicians, it's not something that is seen as frequently in the field as it's stated in the textbooks. So I think next slide is something comes in. Yep, there we go. So the first 2 days, you have vomiting, diarrhea, fever, cough, conjunctivitis, and coryza, which is a runny nose. And basically any kid, that is how most viral symptoms show up. So it's really kind of scary if they show up in your ER or your urgent care and they have those symptoms and you're like, so it looks like, and you check them out, looks like a virus, which measles is a virus, but why don't you go head on home and drink lots of fluids and get some rest and everything that we do. And then all of a sudden, day 3, I'm Koplik spots, which I just talked about, and there's a good chance that new parents going to see those. And then it's only until day 4 that the rash starts peeking in, and that rash is, so they've already been sick for 4 days here. They were contagious for 2 days ahead of them, so they've been contagious now for 6 days, going who knows where with their measles symptoms, which is another reason why measles is scary. Next slide. So complications. So 5 to 15% of patients in developed countries can show up with complications. It's a different thing, different statistics when it's undeveloped countries. So you get otitis media, which is ear infections, pneumonia, laryngotrachealitis, which is an infection here and kind of in your major windpipes. Hemorrhagic measles means you bleed out into your rash. Corneal ulceration is a big one seen on the African continent, and that's the one that the vitamin A is supposed to help with. And that's lifelong, and that can cause permanent blindness. So the next one is encephalitis, which is kind of the big deal. Once again, Wayland, you're going to need to go wash your face. So encephalitis is the big one. It's about 1 in 1,000 cases. Okay, buddy, you are in a horror movie. Is 1 in 1,000 cases. But when you think about it, if you have millions of people getting infected with measles, encephalitis and being 1 in 1,000 is actually very frequent. So encephalitis, like I said, is the big deal, and it's not quite these stats, but I kind of break it up for ease sake. 1/3, 1/3, 1/3. If you get encephalitis, about 1/3 die, 1/3 recover and they're fine, even though it's a little bit less than that. And then 1/3 have permanent complications, and permanent complications can be blindness, can be deafness. It's the infection of nerve cells. So on autopsy, when we look at the brain on autopsy, there's so much inflammation around all these nerve cells. So really, when you're dealing with nerve cells in the brain, anything goes. So you can have permanent personality changes, you can have mental retardation, and like I said, blindness and deafness. You can have paralysis, you can have weakness. So basically anything goes when you start messing with the brain. Next slide. Oh, so I just did all that. Okay, so seizures, that's another one. Okay, I did that. Next slide. Okay, so treatment, I really don't have much for you. So if you come in for measles, which we did have a case of measles at Children's right around the holidays this past year, and it made the news, which is why I can talk about it. But really, I don't have much for you. So if you come in with measles, I basically just support all of your body symptoms to make sure that your lungs are still bringing in oxygen and taking out carbon dioxide, to make sure that your heart is pumping as strong as it could. So I don't have much. I give vitamin A, and I've already told you about that. And then everybody that you've been, that kid has been in contact with, we give them the vaccine. But this is also another reason why measles is scary. Antibiotics don't work. It's a virus. I don't have much to give you if you get measles. Next slide. So, what I can do is just try to prevent it, right? So to be on the offensive instead of the defensive side. So being on the offensive side is a vaccine. All right, so measles vaccine has been around in our country since 1963. We give 2 doses of the vaccine, 1 at a year and 1 at 4 years, so like before you go to kindergarten type shots. With outbreaks though, we will give our babies vaccines that are less than 1 year of age because they are susceptible, but we still give the dose at 1 year of age. So those kids end up getting 3 doses of their measles vaccine. So in 2010, we had a huge outbreak in which we had 32,000 people in Europe.
Yikes. Dr. Nell, you muted yours accidentally.
Okay, I think I was muted for a while.
There you go.
Okay. So we've had a huge outbreak in 2019, and it was concerning. And like I said, we had it here in Denver too. The biggest thing is to isolate these patients as quickly as possible when we do know that they have measles, or even if we think that they have measles. And then basically this is too when you contact trace. And like I told you before, it's extremely contagious. So this is basically every pediatrician, infectious disease, global health experts' worst nightmare is a measles outbreak. What else can I say about it? Okay, next slide.
Okay.
So I don't know if that's gonna work, Mr. Stirrup. Do you
Let's
know?
see. Maybe.
How am I doing on time?
Oh, actually, I can't make that one work. But
Okay. I can keep going.
you and I can talk about that if you want, if we want to drill the kids.
It's a video on vaccines, and there's a lot of vaccine hesitancy nowadays. It started in the late 1990s out of a study that came out of from one gentleman out of, I shouldn't say one gentleman, one study that was published in the Lancet, which is one of our big time respected journals, that was out of the UK. And since then, it caused such a wave of panic all over the world since then. But that study, all the scientists, to be honest, are kind of snooty. We all kind of look at studies and we're like, well, did you do this? Did you not do this? And we are constantly, and you want us to be that way when we look at research articles and research productions, because we want the purest research we can get. So when people started looking at that study, we noted that it was a very small sample size. We noted that there was some sort of pharmaceutical company that was also helping fund it, which also doesn't sit well with us, that if there's other alternative money floating around. And then we tried to replicate it, and nobody could replicate it. And my favorite study came out in about 2003, and it was the entire country. It was either Denmark or Belgium. And it basically, they have socialized medicine. So it was really easy to look at what that article was proposing. And what that article was proposing was that the MMR vaccine, which is measles, mumps, and rubella, causes autism. And that's what Dr. Wakefield was proposing. And for years, nobody could replicate it. And then in 2003, like I said, they had an entire country show their data to see if they could replicate it. Does the MMR vaccine cause autism? And the numbers, it's the entire country. So it's looking at all kids, not just 30 of them. And they couldn't replicate it. There was no higher instance of MMR vaccine causing autism than the regular population.
Next slide. Uh-oh, you paused on me. Uh-oh.
15-year follow-up or whatnot. So in the meantime, then there was some shady stuff that was kind of discovered. The Lancet pulled that research study from their journal, saying that we discredit this. And so much shady stuff apparently went on that Dr. Wakefield lost his medical license. And so there's a couple of doctors in this country. There's a couple of doctors, I know one in Australia, that are still tooting this horn, saying that there's something there, be careful, don't give your kids vaccines. And because of that, basically the world is very hesitant on giving vaccines, or challenging whether our kids need vaccines. And to be honest, I get it. I understand being a mom and knowing the fear of wanting to do everything right by your kid, and then also put a spin into that as far as social media and the fear that can kind of bring up too. And it's just kind of this underground fear that has now made a lot of families choose not to vaccinate. Well, I just told you, and now you are ever so smart to know that measles is so contagious, and if vaccine is the only way to prevent it, this isn't a small choice, and especially being in our country now with these waves of epidemics, that it's not a decision to be wiped away. What else can I talk about it? The thing that made me sad is in 2019, measles really hit the world, and it was at a time when I was looking to go to the Philippines, and the amount of measles in the Philippines was heartbreaking. And what I'm seeing what's happening, and I went to Indonesia instead, but what I'm seeing is what's happening is these parents in these not quite industrialized countries see, well, these moms in the United States and England are choosing not to vaccinate, and they too then get online, and they're like, and then they start saying, well, they kind of have this mentality, well, if it's from America or if it's from the UK, it must be, it must be better than what we have here in the Philippines. It must be better than what we have here in Indonesia. So what was really heartbreaking for me is to see that the amount of unvaccinated kids in the Philippines was quite high, and the reasoning being that they were following the lead of the US and the UK, when that country was just completely slammed with measles. So I think what people I think in the US and UK don't realize is the rest of the world is also watching, and mothers all over the world are very similar, and they just want the best for their kids. And it was very sad for me to start seeing that and putting those pieces together. So anyway, this slide has the Denver Post as far as where we are for vaccination rate, and the Daily Camera out of Boulder. So what's interesting is because measles is so dang contagious, you need to have a higher percentage of your population vaccinated. So you have to have a higher percentage of your population to have successful herd immunity. And herd immunity meaning if one person has it but is surrounded by 5 other people that have been vaccinated, that virus won't spread far. Whereas if you have one person who has measles but the 5 people around him at school, or maybe I should say 2 of the 5 people around him at school are not vaccinated, then that virus is still going to keep going on. So your herd immunity requirement is in the high 90s. I've seen for measles, I've seen anywhere from like 96 to 99% of your population has to be vaccinated against measles for herd immunity to take effect. And as you can see from this slide, these are quoting in the 80s, 80%, but I've also seen as low as the mid 60% in certain schools in Boulder. Next slide. So then this kind of goes into the whole discussion as far as exemptions, and obviously I give this this talk every year, and I do enjoy it because I do enjoy talking to you guys and hearing what your thoughts are and what your questions are too. But I think in the last couple of years, this is starting to come more to a head as far as what's allowed as exemptions. And what's really going to be fascinating is when the COVID vaccine comes up as well. And then that all of us, our snotty research doctors, are really going to be looking at those vaccine studies and knowing, well, how many people have been tested? Well, what are the side effect profiles? Well, what have you seen? So I think when you talk about vaccines, don't lump your vaccines that are currently on the market for like your Menactra, for what we talked about for meninge, and for your varicella chickenpox, and your MMR vaccine, and your HPV vaccine, which is really up in your guys' age category. Don't lump those with the COVID vaccine discussion. Those discussions, as far as medical people are concerned, are two totally different discussions, even though they both have the word vaccine in the discussion. The vaccines that are on the market now have been so extremely thoroughly tested. And if you think of the whole world getting these vaccines, the numbers that we see every year as far as vaccine complications, I mean, these are basically the entire world population. And the vaccines that have been around are extremely safe. And where the COVID vaccine is definitely going to be an interesting discussion. And I don't know, Mr. Stirrup, if that will be on your agenda, maybe not this year, but next year. I think it'll be fascinating.
Absolutely. Cool. And I have to cut you off because I have another Zoom meeting with another medical professional.
Oh, nice.
So I'll give you a last minute to sum up whatever you would like to say.
Well, good thing we're close to the end. Why don't you flip through my slides and see even how much more I have?
Let's see. Immunization.
Their schedule. So you see, it's mostly in babies. Okay, next.
Okay. And how does this affect me?
And how does it affect you? Just hit it next. And I think I kind of touched on that, so that's all good.
We did.
And then next.
And then thank you. And then there'll be a spot in the video that they can type up a question, and I'll email you any questions that the kids might come up with. Thank you so much for your time today, Dr. Nell. I appreciate you so very much.
Thank you. And thank you for being in patience with my little kid running through here too.
Oh, so love it. I wouldn't have it any other way. So I'm going to go ahead and stop our recording. Have a great day. Oops. I'm losing my mouse. There we go. Stop recording. And oops.